centers and urban centers because we have more specialists in that areas. Male to female ratio approximately 3:1, and growing identification across socioeconomic groups. The regional differences here in Brazil. The Southeast region has highest diagnosis rates. Again, because of the number of specialists able to do those diagnoses and the awareness about autism and others developmental conditions. North and Northeast face significant diagnostic gaps, and the rural communities have limited specialist access, as I said before. The barriers to diagnosis and intervention in Brazil. The delayed diagnosis. Unfortunately, average age of diagnosis reach 4 to 6 years at children between this age. And we are missing critical early intervention window. We have to change this. Healthcare access. Limited specialists and resource and public health system create long waiting lists. So we have people waiting for 1-2 years to have access to therapy. And the economic barriers. Therapy costs are prohibitive for many families without private insurance coverage. The cost of the therapy are very high, but the health insurance, the cost to have a health insurance is high too. It's not for everyone, unfortunately. So we have to improve the therapy in our public health system. Family functional priorities in Brazil. The first thing parents can see about their kids are communication. So they came to us looking for improved communication. They come to me, for example, saying, "Oh, Paula, my kid is not talking. She's not speaking with me. I want to hear she's saying, mommy." Oh, but this is the first thing they ask when they look for therapy. So most of the time is about communication. Then comes autonomy and social skills, behavior, and other. As other, I can say food selectivity. We have many kids with food selectivity, and parents can see this, but it's not as much they can see communication, autonomy, social skills, and behavior. A study of 241 Brazilian parents showed 40.7% classified their children as requiring support level 2. This is a substantial support. What is the impact on families? We have mental health impact and financial burden, for example. In mental health, higher rates of depression and anxiety in caregivers because they don't know what to do. They feel guilty. They have a lot of stress in their lives. It's hard. It's very hard. So significant stress related to navigating system. Sometimes they know what to do, but they don't have how to do this. Sometimes families can get the kids diagnosed, but the doctor cannot say what they can do now. They have the diagnosis, but what should I do? And social isolation reported by many families. And I am thinking about this. The social isolation can be because they cannot go outside and to get in contact with other people because their kids are very overwhelmed because of the sensory input of the environment, or because moms most of the time are moms are very, very busy with the kids. They are taking care of the therapy, they are taking care of everything, and they don't have time to do other things. And financial burden. Therapy costs often exceed 30% of family income. Reduced employment opportunities for primary caregivers. So how moms can work if they have to take care of the kids. They have to see the therapy. They have to be there for their kids. Out-of-pocket expenses for specialized services. And the policy contests the national legal framework. In 2012, we had the law number 12764 established the Brazilian policy for protection of rights of persons with ASD. We will see later about those laws. In 2014, Ministry of Health published first national autism guidelines. In 2015, Brazilian Inclusion Law 13146 strengthened the right to inclusive education and health care and autism care pathway by ministry. And in 2019, the law 13861 mandated inclusion of autism in the national census. This was a very important one, all of them. And we will see about those laws. What we have about autism interventions here in Brazil, this is an overview. Evidence-based, what is this? Interventions with scientific research supporting effectiveness and outcomes. We have individualized, tailored to each child's specific needs, strengths, and family contexts. We have alternative approaches lacking strong research evidence, but sometimes used in practice. And the early intervention, critical focus on services before age 6 to maximize developmental outcomes. This is why the early diagnosis is so important. And the core interventions models here in Brazil, ABA, of course, applied behavior analysis that is focused on structure, learning, and behavior modification through positive reinforcement. DIR for time, the developmental approach, emphasizing relationship building through child-led play interactions. We used to say we have to build an effective, meaningful relationship to give the support to development. PACT, parent-mediated communication therapy, enhancing caregiver-child interaction patterns. And Denver is based on ABA, supporting young children by enhancing their social communication, adaptive behaviors, and cognitive development. Let's talk about ABA, applied behavior analysis here in Brazil. The current status of ABA here in Brazil, we have ABA in private clinics. It's very expensive, but parents can have this using their health insurance. The limited availability in public health system. It's hard to get this in public health. It's concentrated in major urban centers. It's easy to find ABA in São Paulo, Rio de Janeiro, Minas Gerais, but it's not so easy to find the therapy when you go to the north states of Brazil. The implementation challenges. It has to be for 20 hours per week, high costs limiting accessibility. There is a need for cultural adaptation to Brazilian context. The way you do ABA in other countries, maybe it's not the way you can do ABA in Brazil. We have to see the cultural, about our culture. A variable quality in practitioner training. So this has to be very careful with the training, and limited generalization to natural environments. How kids will use what they learn from ABA in natural environments. And that's the last topic we were saying about this. Here we have the DIR 4-time model, the principles. D is for development, I is for individual differences, and R is for relationship. So the Afro time is a relationship-based model. The developmental part follows natural developmental sequence, building foundational skills before complex ones. For example, when we say the D in DIR, we are saying about functional, emotional developmental capacities, FEDC. When we learn about DIR, we learn especially about the 6 first capacities. Capacity 1 is self-regulation and interest in the world. Capacity 2 is engagement. Capacity 3, reciprocal communication. Capacity 4, shared problem solving. Capacity 5, symbolic thinking. And capacity 6, building bridges between ideas. And we will see how the kids are going in those capacities. But to see those capacities, we have to know their individual differences, the kids' individual differences. What are individual differences? Respects each child's unique sensory, motor, and process profile. What is this? How kids can process the sensory input from the environment. How is the auditory processing? How is the visual process? How is the vestibular, the proprioceptive? We have to see this to know how to work with the kids, how to get into their world. And when you know about the individual differences and we know how to get into the kids' world, we are able to build a relationship. A relationship based because centers of emotional connection as foundation for learning and development. When you have a good relationship with someone, you want to be with that person. You want to communicate, you want to play, you feel comfortable, you feel secure. That's why relationship is so important. DIR 4-time was created by Dr. Stanley Brisbane in the United States and emphasizes child-led interactions to build communication circuits. What is this? The circles of communication, how to open a circle of communication and to close a circle of communications, building chains of those circles of communications. DIR 4-time implementation in Brazil, current adoption, growing presence in private clinics. This model are growing here in Brazil. Training programs in major cities is a parent-friendly approach, gaining popularity. What is this? Parents can participate of the sessions. They can be in the room with the therapist and the child, learning about the developmental process of the child. So this is important because when they learn about the developmental process, we can there is no such stress in their life because they have the knowledge. So they have less stress. They know how to do, they can understand their kids' individual differences. So now they know what to do. And we have less resource intensive than ABA in New York. The implementation model, typically 2 to 3 sessions weekly. Why? Because parents are in the room with the kids and the therapist. So they learned how to do. And parents can do floor time in their homes. Strong emphasis on parent coaching. At least once a week, they have to have one session of parent coaching. Integration with speech and occupational therapy is a transdisciplinary team to work with the kids and focus on home implementation. We have many places doing home implementation, helping parents. Joy for time, evidence and outcomes. In social engagement, we have, we can see an increase of 67%, improving in initiating and maintaining social interaction. In communication, we can see 58% growing, 58% gains in verbal and nonverbal communication skills, and 71% in emotional development, better emotional regulation and expression of feelings. So when you have effective, meaningful relationship, we provide a safe, secure, and confident environment to the kids, we can get this. Brazilian practitioners report high family satisfaction and cultural compatibility with relationship-focused approach. And here we have PACT model, an overview. We work with video feedback, and parents review recordings of interactions with therapists, guidance to refine social communication ability. I think this is so great. This is very important to see the videos, to have this feedback. We can learn a lot doing this, and how we can help parents doing this. Communication focus targets pre-linguistic skills, joint attention, and reciprocal interactions patterns. And here I can see the relationship growing when you pay attention in those points. I don't know if I can say this. And it is a parent-mediated model. Parents become a primary agent of interventions after specialist training. And it was developed in the UK, United Kingdom, by Jonathan Green and colleagues at University of Manchester. And I really like this model too. PACTing international contest, research evidence, major UK randomized control trial showed significant social communication gains. First autism intervention showing sustained effects 6 years post-treatment. This is great. Cost effective compared to therapy delivered models. And the global adaptations, it is successfully implemented in India, PASS program, adapted for low resource settings, requires minimal equipment and specialist time because of the parents. We have to work with the parents, and potential for telehealth delivery. And we have other therapies in Brazil too. Speech therapy, occupational therapy, physical therapy, social skills groups. In speech therapy, most widely available therapy in Brazil, addressing verbal and non-verbal communication needs. We have to work with non-verbal communications to work with verbal communications. We have to think about the engagement to have a good communication. We have to think about the self-regulation to have the communication, non-verbal and verbal. In occupational therapy focuses on sensory integration, daily living skills, and fine motor development. Me, as a speech language pathologist, I always think about occupational therapy because I cannot do my job if I don't have an occupational therapist looking for, because we have to see the whole body of the kids, the kids' experience in life. So we cannot work alone. We have to think about our colleagues to help us to work with the kids. Physical therapy, very important too, addresses gross motor skills, coordination, and physical development needs. And we have social skills groups, growing availability in urban centers, primarily for school-aged children. So we begin working with kids in one-on-one therapy, but it's very good when we have social skills groups to work other characteristics. And as I said in the slide 7 about the laws, now we will see them better. So autism guidelines, Brazilian Ministry of Health. This is for 2014, I think. Development process, what is this? First comprehensive national guidelines here in Brazil. It was published in 2014. It's a public consultation period, included family input. We have to think about family. And the guidelines scope assessment and diagnosis protocols. We have to use these to know the kids, to know what we can do now. So we have to do assessment and diagnosis protocols, interventions, recommendations very carefully, family support framework. We cannot work only with the kids. We have to think about family. That's why those approaches like DIR and PACT are very successful here in Brazil, because see the families, and we have to always think about this, about the family. Service coordination across sectors, monitoring and evaluation standards. Here we have you can look this online to read the full document. The Health Ministry guidelines, here we have the key points: the multidisciplinary approach, the family-centered care, the community integration, and early detection. So it's very important to have the early detection, because this emphasizes the importance of identifying early signs of developmental issues to start interventions as early as possible. And when we have a multidisciplinary approach, we can see the whole environment of the kids. We can work better. So this requires coordination between health, education, and social service for comprehensive care. And always thinking about the family and the community, because it can impact kids' lives. The more key points, so the diagnostic evaluations will describe the diagnostic process. So we will have to do anamnesis, physical exams, and some more things. Which screening tools we can use. So here in Brazil, we are using MSHOT, and IRDI, clinical risk indicators for infant development. Some states, as Rio de Janeiro, is using ASQ3 to help them with the diagnosis, not only about autism. Therapeutic approach promotes the development of individualized therapeutic projects, and they address the specific needs of each person. So see each person. And the care network emphasizes the coordination of care within the public systems. And here in Brazil, we have SUS. It's very good. It helps a lot. And social services ensuring comprehensive assistance. And how this happens here in Brazil, the pathway. So first, we have the primary care here up on the left. So the basic health center, it will be the responsible for the early identifications, and they can use the evaluation of the child use the instrument IRDI or other instruments as MSHAT, so we can go to here. If the kids is suspected for ASD, the diagnostic evaluations, they have the diagnostic, so the kids can go to unique therapeutic project, to rehabilitation or habilitation, and goes to social protection or specialized care. If the kids, the early identification sees something or knows something, there is something suspect, but I cannot say that this kid has ASD, they will be to the referral for other treatment or rehabilitation, and we will be monitoring this child development actions of early stimulation, multidisciplinary, and medical care. We will keep an eye on these kids. And the guidelines for family support. We have psychoeducation, parent training, emotional support, and parent groups, how it works. The psychoeducation, it's information about autism, evidence-based practice, and their advocacy. Parent training, specific skills to support child development and manage challenging behaviors. This is very important. I have to say this every time. You have to see the parents, because they are with the kids all the time. Most of the time, parents are with the kids. The emotional support, access to mental health services for parents and siblings, because parents' lives are not easy and they are with the kids all the time, and what parents feel can impact kids' development. And parents groups, peer support networks to share experience and resources. Funding and access our public systems, SUS, and private sector. The public systems, we have limited coverage of autism-specific therapies. There is a long waiting list, unfortunately, often 1 to 2 years. The universities here in Brazil can offer the services too, but we don't have. I wish we could have more specialists to work with the kids, but we don't have in public systems. Therapy frequency below recommended intensity, and uneven quality and specialist availability. And private sector, wider range of interventions options, some insurance coverage after 2013 court decisions, because parents fight for this. High out-of-pocket costs, the therapy is very expensive, and concentrated in wealthy urban areas. So this is the disparities in access here in Brazil. In Southeast, we have much more access to therapy. In South, we have good access too. But when you see North and Northeast, it's very sad. It's very sad. We have to change this. Usually people from North and Northeast come to study in Northeast, and they don't come back to their regions. So this is the Autism Pride, advocacy and social movements. From 2010 to 2012, there were the first major parent associations formed, leading to Law 12764 passage. From 2013 to 2016, legal battles secured insurance coverage for therapies through court decisions. From 2017 to 2019, push for inclusive education protections and autism identification card. And from 2020 to present time, focus on implementation of ministry guidelines and expanding public services. And I hope we can get even better. Integration with schools inclusion policies. We see there are laws that make schools accept people with autism. So the policy framework, National Education Plan mandates inclusive education. Schools cannot refuse enrollment based on disability. When they do this, parents can sue the school because of this, because kids have the right to study in the place that parents choose for their kids. Individualized education plans required. And it's because they have the individual differences. So we have to have the individualized education plans. Specialized support professionals guaranteed. So they have to train their professionals. And what are the challenges? Inadequate teachers training and autism-specific support. We have to go to schools to help teachers. Shortage of specialized education assistants, limited coordination between therapy and education. That's why it's so important therapists go to schools, to talk to teachers, to talk to assistants, to align what they are doing, and physical accessibility and sensory accommodations gaps. And the main challenges to policy implementations, we have budget constraints, insufficient fund allocation for specialized services within public health systems. Yeah, money, it's all about money. Fragmented system, poor coordination between health, education, social services sectors, workforce gaps, so shortage of training professionals, especially in the public sector and rural areas. So we have to make this better to help kids, train the professionals to work with the kids, and monitoring weaknesses. We have limited data collection on implementation and outcomes of interventions. So we have to be more careful with this to see how we can change what is happening to make things get better. The research gaps in Brazil, our current research status is growing, but still limited. Autism research concentrate in a few universities. For example, I am doing my postdoc and I did my PhD in University of São Paulo. It was great, but here I live in Espírito Santo. Here in Federal University of Espírito Santo, we don't have the money to do the research. That's why I went to University of São Paulo, because we can do research. here in my state, we cannot do research. We don't have money to do this. Minimal government research funding, and few clinical trials of interventions. And the priority research needs, effectiveness of interventions in Brazilian context, cultural adaptations of established models, cost effectiveness studies, implementation science for public health system, epidemiological studies on prevalence. We dream about the day we will be able to offer therapy for everyone in a public system. Key takeaways and discussions. Intervention models. ABA, DIR for time, and PACT represent core evidence-based approaches being implemented here in Brazil. The future focus, early intervention, family empowerment, very important, and service integration offer greatest potential impact. The policy advances, ministry guidelines provide framework, but implementations face significant resource and training barriers. Have to change it. Persistent gaps, regional disparities, delayed diagnosis, and limited public services remain critical challenges. And future directions, implementation science, developing framework to effectively scale evidence-based in practice within Brazilian system. We are working for that. Integration of service, creating seamless coordination between health, education, and social services sectors, and workforce development, international experts providing training in DIR for time, PACT, and other models to Brazilian professionals, especially in public sector. We from University of São Paulo, we will do this for the public system. We'll have to begin this in the next year. And family-centered models, shifting toward empowering families as primary intervention agents with professional support. Why? Because parents are with the kids all the time. So they need to know about the development. We have to help parents, and then parents will help the kids. And thank you very much.
Fantastic. Thank you so much, Paola. That was so interesting and extremely comprehensive. Fantastic overview of the state of services for autism in Brazil. I think we've got a bit of time for some questions. So if anyone has a question, please do ask. You can speak in Portuguese. We can translate for Catherine and the UK English-speaking attendees as well. So while we're waiting for anyone to make their questions, I have a question about your work on DIR floor time. So I wondered if you could just mention a little bit more about where it's possible to get training and like what kinds of services it's been implemented in so far in Brazil.
I love to talk about DIR. This is my passion in life. You can have the training with ICDL. It's an American approach. So you cannot have in Brazil. We can have online, and there are some people doing in person here in Brazil, but you have to pay attention because only ICDL and Profecton can give the certification. So Patricia Piacenti do the in-person course here in Brazil, And me and more 8 training leaders work for ICDL teaching online course. We have a 101. It's an introductory course. It's 12 hours only, but this 101 don't give you the certification to be DIR full-time therapist. So you have to take the other courses, 211, 202, 203 to be. And 211, 202, and 203, each one takes three months. It's a 3 months course. So it's a long time course to get the certification, but worth every second and every dollar you pay for it. It's
There,
expensive.
yeah. I mean, it should take a long time and it should be expensive because these are models, therapeutic models that you're going to use for the rest of your career. So it's really important.
Yes.
And is the training available in Portuguese or in English, in Portuguese as well?
Yes, we have classes all over the world in many languages, and I teach in Portuguese. Me and those 8 training leaders, we give the course in Portuguese.
Thank you so much.
Okay.
So I think someone has a question in the chat. Okay, so sorry, I'm not sure what this person's name is, but they're kind of feeling worried about the question of early diagnoses, even before we talk about investing in early interventions, because a lot of children in Brazil are growing up in very vulnerable situations, adverse situations. Okay, so her question is if PACT requires a diagnosis. No, it doesn't. So PACT, as Catherine will explain now, PACT is for children who have social communication difficulties. They don't have to have a diagnosis. So you can enter with PACT even before the child has an established diagnosis. And actually, as Priscilla is going to talk about, in Brazil, we've done some work with families who are living in very adverse, vulnerable situations who don't have access to diagnoses, and we applied PACT in those situations for exactly that reason. So that's a brilliant question. Thank you so much. Okay, so I think, Paola, thank you so much once again. It was really lovely to have you here, and your talk was just brilliant. Thank you so much.
Thank you.
Thank you. Okay, so now Dr. Catherine Aldred is going to present. So Catherine is one of the developers of PACT with Jonathan Green from the University of Manchester. So Catherine is a speech and language therapist and developed the intervention over a number of years and has tested it in various high quality randomized control trials and leads the organization that makes PACT available all over the world. So it's a real honor to have you here, Catherine. Thank you so much.
Thank you for inviting me, and it's a real honor to be here. And we're thrilled, absolutely delighted at this opportunity to work with you in Brazil, as we are global, and it's fantastic to work in many varied cultures and countries. And I'm really impressed with the progress that you've made already in Brazil. That's a real dedication from the individuals that have been involved in disseminating and promoting the interventions, evidence-based interventions. So I'm going to talk about PACT, evidence-based neurodiverse affirming intervention. I'll explain a little more, building on Paola's introduction, a little more about how PACT works, what it is. I will also show you a video and give you a little illustration of how we do the feedback in PACT and the principles and theory behind it and benefits to services and the families. And then I'm going to pass you on to my colleague, Professor Jonathan Green, who will tell you a little bit more about the scientific evidence behind PACT. So PACT is unique in that it doesn't work directly with the child. It is a parent-adult mediated intervention using video. So the importance is it's using video is a fantastic opportunity to make in-depth, insightful observations of adult-child interaction. And through video and techniques of video feedback, which I'll explain, we can enhance the child social communication interaction in a way that we're building on the dyadic interaction. So PACT works through adults who have really important roles in the child's lives. Those are starting with parents, but also other caregivers, guardians, teachers, teaching assistants, people who are there on a regular day-to-day basis. And it is for children who may be possibly autistic. This includes toddlers where through screening, we're identifying some red flag signs of a possible autism, but it's not clear yet, through to children where it comes clearer. And some of those children at a certain point will receive a diagnosis. So it can be both before and after the diagnosis. And it's been available for children aged 2 to 11 years. That's because that's the cohort we've done our research on. That's not to say it's not suitable for older children. We just don't have the evidence for that. So we've been training both health and education professionals, but they are facilitators, so they're trained to be facilitators to support through the techniques of PACT, video feedback, a more aligned, adapted interaction with the child. The efficiency of PACT is that it can be delivered in the home, in the education context, whether that's daycare, nursery, preschool, school, centre-based, or online. And what's important about the online development is that this makes it easily accessible at convenient times to meet the demands on families, and may involve both parents if that's preferable, and it can be weaved into their busy daily lives more seamlessly without the need to travel or waiting rooms, and without the distress of taking the children to unfamiliar settings. So online delivery, because we're using video, it's naturally lends itself to online delivery, and it means we can reach the most remote areas and it's more accessible. So some of the video feedback techniques, I'll demonstrate this in one of my videos, but there are many skill techniques that we train on. This is including, first of all, learning how to identify the best clips. So there's a way of learning how to observe, first of all, and this gives the professional the opportunity to stand back, observe, reflect, and look at how the interaction can be adapted to achieve the best optimal fit with the child's profile. So the theory behind PACT is it's celebrating the child's uniqueness, their neurodiversity. It's harnessing their unique skills and attributes. It's a strength-based model building on the child's unique motivations, skills, attributes. Already assuming that the child will have motivations, curiosity, things, desires, and explorations that are in their own mindset. And the aim is to create an environment that recognizes and harnesses those interests, observe the child's mindset, their emotions, their responses, their arousal level, their pleasures, what engages them best, and the adult learning to adapt to that in a way that builds and strengthens the child's agency and initiation. So it's empowering the child. So we'll explain how we bring about that balance in the interaction through the video feedback techniques. PACT is modest. It involves 12 sessions of 90 minutes duration each over 6 months with optimal continuation if that's appropriate. That's based on our scientific evidence of the optimal dosage or optimal amount to bring about the demonstrated results. It's a collaborative partnership, so simultaneously PACT supports adults, parents, caregivers, recognizing that they are going through a journey of discovery, that there will be left with some confusions and perplexity, that the usual conventions may not apply for unique children showing differences in their development. And therefore, it's building on the adult's existing historical knowledge, first of all, of the child, their past experiences of the child, what they know the child likes and what they do well, but also tapping into their innate insights and intuition. So through the use of video, we can show best clips, and then we ask the adult, what do you see happening here? How would you interpret that? How is that supportive for the child? What are you doing differently that makes this moment work well? And in this way, through a series of prompts, we're tapping into the adult's insight into the child and deepening their observation and insight. So they're able to objectively step back through video. They're not participating, they can step back and make observations that may challenge their original concepts and conventions, and then suddenly realize that there's a different type of interaction going on here than they thought, usually better interaction than they thought. The child is giving more skills than they originally thought, and they themselves are demonstrating more skill than they realized. So by tapping into these best clips, these best moments, we empower, we give confidence, we make adults feel secure in their sense of I know best. And that's quite an important feeling for adults to feel validated and feeling they are doing the best for the child. And that leads to then adaptation in terms of having a roadmap, a vision of moving from confusion to something that is aligned with the child and gives you an opportunity to read the child moving forward on a moment by moment basis. We ask these adults, whether it's parents or teachers, teaching assistants, to have 30 minutes daily practice where they've set themselves new goals. Those goals may be, for example, to be less directive, to observe more and notice the child's signals, to respond slightly differently when the child gives a signal, whether it's an emotion or a communication signal. And in this way, the program is uniquely individualized to each child because we have very, very many variables that are impacting on these children and very variable temperaments, personalities, attributes. So in this way, PACT is process driven. It does not have set targets that each child should get to. Instead, it's a process of building the maximum child empowerment, child initiation, child feeling validated, that they have a means of communicating that is recognized and feeling understood by the important adults in their environment, and the adult environmental adjustment around the child. So in turn, this strengthening of the child, starting with existing skills in the child and the parent, strengthening their signals as becoming agents, feeling they have the power to be understood and signal their needs, wishes, wants, and emotions to adults in turn leads to stronger socialization. And in turn, as Jonathan will explain, this has long-term benefit, which is proven in our research studies. So in turn, adults become empowered in recognizing and enhancing their skills. And in this way, PACT it's not a teaching method. It doesn't coach, teach, or encourage masking. Instead, it's relationship-based. It's strengthening this alignment, which we also call synchrony, a connection, an interaction, and engagement, which is proven to lead to better child outcomes. It does facilitate this development of initiation and reciprocal interaction. So we call it handing the floor to the child. It's instead of the adult stepping in too quickly, the adult is leaving pauses and opportunities for the child to take a turn or to step in. This is very important to get the adjustment in timing and pace, where sometimes adults may feel themselves under pressure to intercept, to be driving it. So it takes the pressure away from the adult in a way that the adult trusts the child, that they do have innate motivations, desires, allows the child to take an equal turn commanding the floor. And in those moments, even looking at brief moments where the child makes a signal to the adult, by looking at those moments on video, we can magnify them and show that that was a stronger signal than we actually realized in the moment. And we learn to recognize these missed opportunities through video review. And the adult then learns to step back a little and allow the child to take their response or initiation and know how to facilitate and support that in a way that enables the child to grow in terms of the strength, frequency, and purpose of those communication signals that might be seen in the child movement, orientation, body posture, glancing. It might be a gesture, it might be vocalizations or other signals. Sometimes adults will even say, I sense something there. It might be just something we can't even see on video. But what that does, the video feedback, is a very good way of stepping back and reflecting on that experience, whole experience that the adult had in that moment. So Jonathan Green will be talking about the scientific evidence, but this is long-term successive trials, and every strategy within the PACT manual has been evaluated and developed through the trial, so it has scientific background. It's developmentally orientated and informed, so we do support successive skills, and the stages move from building episodes of mutual shared attention in which there is opportunity for interaction, communication to occur, building synchrony in the responsiveness of the adult, and then helping the adult adjust their style of interaction to match the child, both their non-verbal and their verbal contribution, and then building and empowering the child's initiations and the purpose for which they communicate. So this is where, through the video, we're observing imperceptible moments, and the video clips may be anchored in a child's motivation, their emotions, or their intentions and thoughts. And usually we'd ask for a 10-minute video of adult-child interaction. That may be made, if it's online, parents can send that remotely in advance of the feedback session, or the school could send it remotely in advance. Everybody reviews the full video, full 10 minutes. And then we ask the adults to select their 2 best clips. We normally identify the same best clips. Normally that's quite clear. Sometimes if the adult has difficulty, the therapist would help the adult by saying, I really like this moment and I'd like to share it with you. And always this is framed in a way of looking for the positive attributes, because we know that it's sensitive, that everything is fragile because the past experience for many adults will have been a disempowerment, feeling lost, feeling confused, not knowing whether they're getting anything right. So we want to show them what is working well first. This is what you're doing. This is very important. Explain why it's important, because we can see how the child, what they give to this interaction when they have this type of support. So in this way, we're also harnessing the child's attributes. So a child that may be a problem solver naturally, or a child that loves fixing things, or a child that's really interested in sound or motion. We can tap into that and say, he loves this. This is a lovely activity. You have got his motivation and pleasure. And we can show when those moments of sharing that pleasure with him extend the duration and length of attention focus. When the adult comes into things that they may think are unimportant, we can demonstrate this is important because he's sustaining his attention focus at this moment. So how does PACT work? So as I said before, we have a approximate 10-minute video. It may be 2 or 3 small video clips making a total of 10 minutes, particularly if it's made in the school or the home setting, sent in advance. Everybody reviews that full video. Then we meet online or face-to-face, watch the clips, the best clips. 2 may be enough, and we discuss mutually what we're seeing in these clips. This is where the adult brings their knowledge of the child and insights, intuition, but the therapist brings their knowledge of developmental skills, of their professional input, guided by the manual. So the manual is guiding you, therapist, through the successive stages that are incremental and cumulative. So we start by building skills that follows a process, a journey. But within each of those stages, there are strategies that will be uniquely selected for each child, identifying what's there already and identifying what's adult skills brought into it and seeing where we can enhance those following the framework of the PACT manual. This is where the style of delivery is using probes instead of telling and advising the adult, this is what you should be doing, because instead it's asking. So it's tapping into the adult's understanding of that moment, what they're contributing, and how it's building the child's skills. And from that discussion, we summarize and ask the adult, of all the things we talked about, what was important? What would you take away? What would you practice? And the sessions are usually 2 weeks apart, although there's some variability depending on how it's delivered in that particular country. And then there's a written summary which is personalised, highlighting the skills and the strategies that the adult will practice. So now I'm going to play you this video. You will see here, this is a young child with his father. They have a bowl of bubbles. It's just got some foam from some bubble bath in a bowl here. You'll see a very brief clip. So this is a best clip that the father had selected. He knew this was something, felt good about it. So we're reviewing this clip. You'll see in the corner here, we're on Zoom. So there's myself and both parents are joining the PACT feedback session, but we have different clips, 1 clip for the mother and 1 clip for the father. So we're just playing the father's clip at this point. So do you want to watch this whole clip, and then I'm going to review it with you to look at a clip within a clip, which is things that can be missed. Fabulous. What do you think of that moment?
It was really nice. And he's looking up at me to sort of see if I'm responding to what he's doing. And I think I am responding to it. And yeah, he's sort of come physically closer to me, like his feet are touching me. He just seems very comfortable with me.
Okay, so you can see that just a probe, what do you think of that moment, opens up that reflection. And the key words are, he seems very comfortable with me. And that's very validating of the relationship. And the adult says, I think I am responding to him. So let's just look again. And there may be little moments in this video clip, watching it a second time, that you'll see that we didn't see initially. So by watching it a second time, we can put tiny moments under the microscope and accentuate them, make them more prominent. And then once somebody has seen that, we know that's something the child can do. We know it's there, and we can look for it more frequently. So I'm just going to go back to the start and see if I can pause it. Okay. So I'm going to see if I can just move this moment around a little. Okay, can you see that? So I'm highlighting a moment where I'm showing a reciprocal interaction, a gaze directed, and then a gesture, lovely gesture, and a look. And the adult looking, reciprocating. So not only do we have a moment of shared attention here, they're both engaged in the same activity, that we have a moment where the child is showing a higher skill, more skill than we thought he was. And so not only does the parent say, I think I'm responding right, we can say it's absolutely right, because look, what else you get here. This is a wonderful moment. And if we're going at this here, I really like the way you did this here with the foam, putting the foam on your hand. And what happens next? This. So in this respect, we'd say, tell me about that. That was a lovely moment where you put the foam on your hand. And this is where we would say the parent is being non-directive. He's not putting any demand or pressure or expectation on the child to touch the foam. Instead, he's just putting it on his own hand. And in this way, it's a nice slow pace, and it incentivizes, it motivates the child. And it gives the child a locus of control where he's watching, he's interested, he's curious, he's looking at what the adult is doing, looking at the adult, so referencing the adult, and then say, I'll do it too. And where we've got a gesture, because there was glancing to the adult, orientating the adult, and a gesture, I can do it too and get bubbles. And so we will look at these moments under the microscope, do a little microanalysis so that the parent sees the full value in this low demand, we call it synchronous interaction, where he's slowing it down, he's slowing his pace, he's responding in a very complementary way to the child without teaching, testing, or directing, but instead is doing it in a way that he's already got existing child motivation, and he's bringing the child into the interaction where the child makes an equal contribution and then signals the child is communicating. So in this way, we would say to the parent, so what goal would you set? Because he said he's comfortable with me, but we would say, why do you think he's so comfortable with you? What are you doing that's supporting that? And the parent would reflect further on, well, I'm going slowly. I'm not putting pressure on him. I'm not expecting him to touch.
Press 2 for blood test appointments. Press 3 to discuss clinic appointments.
Sorry, I've got a that's sound there. And out of that, we'd write the program. And in the parent's own words.
We're sorry to keep you waiting. We appreciate your patience.
Sorry, there's still a noise somewhere.
Can I say your test number?
Yes. Oh, goodness. Hold on. Let's find it.
Jonathan, I think we can hear you on
446 695 3228.
Okay. Oh, that's fine. It's muted. So in this way, it's a process of guided discovery, guiding the adult to discover the child's existing skills and competencies, motivations, style of communication and learning, and adapting the interaction sensitively and timely. So we call that better attunement. And in this way, it's a better balanced interaction, is a better alignment in enhancing existing skills and supporting a strength-based growth mindset. And first of all, parents or teachers may start with 30 minutes practice a day. That's just because life is very busy. So to put aside a little time where you can actually at the end of the day say we had a window of quality time where there were no external demands, just focus. It's very rewarding for the adult because otherwise adults can feel I've done nothing all day because everything seems to be demanding. But putting aside a quiet time, a special time for relaxed, enjoyable interaction. And then at the end of the day to feel validated, at least we had that. But then what we would aim to do is saying, well, those micro moments can happen at other times of the day. It can happen going on the bus, walking down the lane, in the car, in the bath, snack time, bedtime, or other moments where there's just an opportunity that the child brings to the adult, a moment where the child signals, I'm ready, or I'm with you now, so that we can weave these strategies, these skills, this responsiveness into everyday settings until it eventually becomes a whole mindset that adults carry around with them. And this is an interesting testimony because this is an adult, a young person, who gave us his experience, his lived experience of receiving PACT and his journey through PACT. So he talks about shared attention that he felt in the early years of PACT, and gave me the skills of knowing how to share. Let's call it a shared experience. I'm an open person who gets on with everyone. It's like, come on, join us. It was an exposure to those sensitive adults. I thought, this person is interested in me, knows what I'm thinking, sees what I see. It was just having fun. It was play, enjoyment, your style, things you're really interested in, and building a relationship. Yeah, the child finds a way, like he's always, once you join it with me, I'll join you. And it's a connection. Even my teachers seemed like friends in that relationship building. You felt like you were connected to someone, even if it's just like a very small thing. And this is a young man who's doing great things with his life now. And he started off nonverbal. He had early years PACT with his family, and then he had PACT in school. It became more of a PACT ethos in school, I'd say. But he really gave a testimony that validates his experiences. So what are the benefits for the autistic child and families? So fundamentally, as with any young child, but even more so for children with these differences in their style of communication and interaction, to be understood is absolutely validating and critical to start to understand others, because it becomes having a bidirectional effect. It's backwards and forwards. The child's sense of agency, the child's sense of I can make other people understand me and do things that I want and need. I can express my needs, wishes, and wants from both most basic needs, basic communication of hunger, discomfort, comfort, to more higher order needs. I'm interested in this, look at it. And giving them a sense of empowerment and increasing their initiations. There's strong evidence, as Jonathan will describe, about the child's sense of initiations, communication initiations, and agency being strongly correlated with better outcomes. The child's sense of relatedness, connection, and engagement, as we heard in the previous testimony, a sense of their motivation, their innate motivation to be connected, and then experiencing improved relationships is an anchor. It's the backbone of learning, of their journey. Also reduce distress-related behaviours. So, the child's experiences of their sensory world and their experiences of different situations, having an environment where the adult understands, even if sometimes we can't change it, just that understanding and being able to assuage in a way that's giving the child a sensitive sense of, I feel what you feel. The early support, and critically, the one key message to take away from this webinar is the early the better. That early support is a catalyst for better development, enabling these children to flourish to their full potential. And we have found through the research is a strong predictor of the trajectory of their journey through their later developmental experiences. And this intervention is graduated and phased according to need, whether the child is nonverbal or verbally fluent, whether the child has whatever their style and their profile, it's equally adapted to each individual child. Benefits to services and professionals. The benefits are efficiency and effectiveness. And just as parents need validation, professionals do too. And it's very important for us to know that we're following the best evidence, the best scientific evidence, that whatever we do, we have worth, and our time is of worth, that there's evidence behind it, and that we can use it in the most efficient way. Hence, actually, the move to a lot of online delivery, because that means there's less demands on traveling, and if we can do things online with the use of video, we can see a picture of the child which is representative without the need to always travel in different directions. It's versatile, accessible at the point of need. And we have user experience, which is very positive. That's published in a qualitative study. So this enables services to work with the child's environment, identify these light bulb moments, relatedness. And we know that the benefits have been proven independent of the social, economic, education, culture, or ethnicity. So PACT trials have been replicated. We've done feasibility studies in different countries, different cultures globally. And importantly, this early intervention reduces the need for secondary crisis management. So how just a little bit about the training impact. So it's embedded in the new autism care pathway, which I'm sure Jonathan will talk about. It's aligned to a more continuous support and care, where it's enabling better understanding, and if a diagnosis is appropriate, that can be weaved in the middle of this and continues to post-diagnostic support. There's a level one, PACT level one, which is an e-learning program, introduces PACT, both the research, the theory, and the stages, and that could be standalone training. That's just a 90-minute training program, lots of video examples of the PACT style, may be suitable for teachers, professionals just interested in knowing the ethos behind PACT. For those practitioners that want to go on to become certified to deliver PACT, they do level 1 first, and then they go on to level 2, which is live 2-day or 4 half-day training with lots of videos of the 6 stages of PACT, small group role play, and some post-course supervised practice to become certified. It usually takes between 6 and 12 months to be a certified practitioner, and you receive the PACT manual. So level 1 is for a wide range of carers, professionals, teaching assistants, service leads, and level 2 is suitable for professionals who want to deliver PACT, and we ask that they have 2 years experience of working with families of neurodiverse children or autistic children. And thank you for listening.
Oh, that was fantastic. Thank you so much, Catherine. Gosh, what an amazing account of the young person's experience of receiving PACT. That's the first time I've heard that. That's really amazing, really.
Yeah, we're doing a project where we're going to seek the people, the children that were involved in the original PACT trial will now be teenagers
Yeah.
or young adults. So we're doing a trial of seeking their views, priorities, experiences.
Oh,
So that will be just a really interesting piece of work, and their reflections, because I think we want that it's grown through the insights of both parents and of young people, young neurodiverse people. So we want to make sure we hear their voice.
yeah. Thank you. Okay. Does anyone?
Here there's the website. There's a website with more information, and this is our email, info@pacttraining.co.uk. If people are interested in any other information or have any questions, feel free to contact us.
Thank you. I think someone has made a question. Yes, so so Valence from my department, she really enjoyed your talk. If there are any questions, please feel free to ask. So Catherine, just to reiterate, because that's really striking. So that young person had been non-verbal when they began PACT as a child, and they now can communicate to that extent. That's really incredible. And amazing to hear that they had such a positive experience.
I think what comes across from meeting the young person now with his parent is the sense of still that relationship has been, and then the relationship with teaching staff as well. He had a really positive experience, and he's anchored in that. You know, you can sense that those relationships are absolutely formative. But yes, you know, we're not looking, we're looking at each individual child's journey, and we don't have a crystal ball, so we don't know what the journey will look like. But I think the emphasis is to enhance the skills that are there, and work with the style of the individual. We're not about changing that. We're about bringing out those strengths and then having it's a more nurturing, supportive environment, scaffolding the individual. And at the same time, sort of helping parents and education understand his style is. This is how this young person sees it, how he processes information, how he feels comfortable is key. And when we build those better relationships, better understanding, we've got the bedrock on which development happens. These young people flourish, and we may also give adults a lot more confidence and belief in the young person, and vice versa. The young person belief and confidence in adults, which is quite fundamental.
Yeah, absolutely. Thank you so much, Catherine. That was fantastic. So we can have more of a discussion with everyone at the end as well. So Jonathan, so now I'm very happy to welcome Professor Jonathan Green. So Jonathan is the other developer of PACT, and he's a professor of child and adolescent psychiatry at the University of Manchester, and he kind of spearheads all of the research that's happening around the world with PACT. So thank you so much, Jonathan, for being with us today.
Hi there, it's a pleasure. Can you hear me all right?
Yeah, we can hear you.
Brilliant. And let's just can you see the slide?
Yes, we can now. Yep. Mm-hmm.
Lovely.
We can see it in presenter view though.
Okay, let me just see if I can shift that. How about that?
That's fine now. Yeah.
That's better. Okay, lovely. So thanks, Lizzie and Priscilla, and it's a pleasure to talk to you, particularly complimenting Catherine's talk on PACT. And really, I'm afraid, delve into a bit of sort of science stuff now, but really, to be honest, what you heard from the young person who'd grown up after PACT therapy just now from Catherine kind of encapsulates it all, to be honest. What I'm going to show you is the way that we've looked at this in a science way and hopefully just flesh out some of those themes. But hearing the young people, obviously we've done all the science work I'm going to explain to you before we heard from that young person. And so, and people like him. And so that was very validating on the sort of work that we've done to evaluate PACT in a scientific way. So please, everything I talk about, just hear in the context of what that young person really said about their experience, because that's the real life version of it. But the structure really for helping us understand how a therapy like PACT works is that we need to have what we call a logic model, which is a theory about how we think the therapy is going to work. And if we have this, then it enables us to test out whether actually that's actually what happens in practice. So here's the logic model of the therapy. And, Catherine's already explained this in slightly different terms, but as she said, the therapy works directly with the parent using video feedback. The idea of that work is that we improve the parent's understanding, attentiveness, and ability to make sense of their neurodiverse child's communication. That will automatically then improve the quality of their response to the child. The more you understand someone, the better you're able to respond to them. And the idea of the therapy then is that the child will respond to the parent's change. That's kind of the magic of it, because we, as you know, don't work directly with the child at all. And this raised a lot of eyebrows when we first started to do this work, and still does to some extent. People think, oh, you've got to work with the child to make a difference to the child. And what we're saying, no, we are working in a naturalistic context of how children develop ordinarily in families. So we're expecting that the child's going to respond to the parent change by a change themselves. And we are hoping that that change in the child with the parent will then be what we call generalized out into their relationships outside the family. This is a big, as it were, gamble or hope that that's what's going to happen. But we've got lots of developmental evidence that that's the sort of thing that does happen. And that actually, if we then follow up the families after the end of therapy, if we've succeeded in introducing this change inside the family, then this might continue after the end of therapy, and that would be the ideal. So that's what we call our logic model. And the initial large-scale test, we'd actually did some work before this, but the large-scale test was this study that we reported about 10 years ago now, so this is not new, which was the large-scale trial of PACT funded by the Medical Research Council in the UK. And the important things to show here are that we were looking at a group of children, preschoolers, who were quite, they had core autism. So these were quite impaired, developmentally affected children. 80% had learning difficulties of one sort or another. Only a quarter of them had phrase speech at the beginning of the therapy. So I'm emphasizing this is what we at the time called core autism. This is not spectrum condition. We don't use this term anymore, but when we started, this was the idea. You can get the feel for the kind of children these were. And we followed them up. We did the randomized them into a group who just had ordinary care that they would be getting anyway. And then another group who got PACT in addition to that ordinary care. So that's the contrast that we were looking at. Then we put PACT in here, follow them up initially at 13 months at the end of PACT therapy, and then again when they were 10 and a half years. So this is a very long follow-up, 6 years after the end of the therapy, which is unique. No follow-up like this in a randomized trial has been done before or since. And this is when the kids then are in middle childhood, and we succeeded in getting an 80% follow-up. So this is the structure of the trial we did in this PACT trial. We published it in a number of publications in this journal called The Lancet, a couple in The Lancet and in other publications too. This one's 2016, but there have been others since then. And basically, this is what we found. And all the graphs I'm showing you are going to have the same sort of structure to them. So here's time along the bottom. This is when we started. This is the end of therapy. And this is the follow-up period. So you can see how long the follow-up period is compared to the period of the therapy. Give you a perspective on it. And up here is what we call the effect size, which is basically the difference between the groups, which represents the result of the effect of the therapy. So the first thing to show here is that by the end of the therapy, the parents really had changed their understanding and response to the children in a very impressive way. So this red is the PACT group, and this blue is the treatment as usual. This is a very big effect size between the groups. So this was the effect of PACT on parent, what we call synchrony. If we followed that over time, it didn't get any change by the time they got to 10 and a half years. And there are various reasons for that, possibly the measurement and what we call synchrony doesn't really have the same meaning here. So we weren't sure quite what to make of this, but that's what happened. And then in response to the parents' change in synchrony, here is the child's what we call communication initiations. This is social engagement, spontaneously making an approach to the parent. This is not in response to something the parent does. It's spontaneously wanting to make contact and communicate with the parent. And what these children show is that increased over the time of the therapy. It's not such a big increase as what the parents, but it's still a substantive increase. And the key thing we saw is that continued right the way through to when we followed them up in middle childhood. So by middle childhood, they were still doing as well as they did at the end of therapy, pretty much. And that's a remarkable result, really, very significant. Since most therapies, after the end of them, you get this thing called washout. The effects seem to sort of drivel away, and it didn't happen here. Then we looked at the thing that we were, in a way, most interested in was how the child was going to do outside the family. This is the third bit of the logic model. And here we used this measure called the ADOS of autistic behaviors. And what we showed was that these reduced. They didn't go away, but they reduced by the end of therapy. And that reduction continued in the same way right the way and through the 10.5-year period. So this again was an extraordinary result, really, in changing the autistic child's behavior, adaptation, social communication, sensory difficulties. It didn't make them go away, but it reduced their impact. And that was seen to be a very significant result. But it wasn't the only thing we saw. There were all sorts of other things we looked at in terms of social communication, overall adaptation in the community, measured by parent report. How well are they getting on in everyday life? What we call the family functioning. I had a measure for this, particularly child development. This was measured by parents. And in one of our studies of this kind, challenging behavior. This is at the end of therapy. And then at follow-up, the family functioning was continued to be improved. The teachers reported an improvement in the child adaptation in school, which was very nearly significant. It was a powerful trend, and I'll show you about that in a minute. Parental well-being was significantly improved, and child anxiety showed a substantive trend as well, improvement in child anxiety. So this is all at 10.5 after preschool PACT. So there were a range of different outcomes. And just to bed that into some comparative results with our other therapy we did with babies before diagnosis of the similar kind to PACT. And here we saw exactly the same result. So this is to show you that this effect in PACT on the ADOS was replicated here in the iBasis interventions over time. The follow-up length wasn't as long here, but you got the same pattern of effect. So these are powerful results, and we were interested to discuss with the autistic community about the ADOS results because these were in some quarters controversial. And I just want to touch on this here just for your interest. And this is a complicated debate that I can't go into in detail here, but basically when we reduce the ADOS in the way that we've done and showed in this, we are not, it doesn't indicate that we're taking autism away, which was some people's fear. And when we get into dialogue with autistic advocates and the community of autistic people and families, we've had a lot of discussion about these results so that we can understand them together. And basically, this quote here comes from a group of autistic advocates who we're in dialogue with, who are really saying that they understand what they think is happening here, which is not that neurodiversity is being got rid of or autism's being taken away. It's that the autistic child, the neurodiverse child, is more comfortable in their own skin, they're less stressed, they more feel able to relate to the world. And let me just come back to what Catherine was saying about the young man talking about his experience. This is kind of reflects this. And what the ADOS actually does is it measures all these kind of what they call struggling autistic child. And what we're basically, the reduction in ADOS is basically still an autistic child, but a more comfortable and happier autistic child. And that's what we're measuring in the ADOS improvement. And it gives us lots of things to think about what actually autism is and how we should really measure it. Can't go into all that now, but it was some of the results of our trial gave us real cause for thought about that. So as we've talked to the autism community, autistic advocates about the results, I think people are really reassured that this is a neuroaffirmative process here we're talking about. And the ADOS reductions are meaningful, usefully meaningful for the child's life. We also showed that the intervention, as we do it in PACT, is cost effective. This is important for policy, of course, for people who have to pay for services in communities. And basically what we showed in PACT is that when we looked at, or we didn't do it, but a group looked at, from London School of Economics in London, looked at the health economics when the children were 10 and a half at the follow-up of PACT. What they basically found when they modelled this, that was about a £50,000 saving per family when you totted up all the benefits of the therapy over time. So that's a powerful effect, and that was significantly cost effective. And it led to PACT recently being nominated by the London School of Economics in a report to government as the top economic case for autism policy implementation. They were recommending in the UK, but obviously it could be elsewhere as well. So cost effectiveness is a very important consideration, as well as the lived experience of families and the outcomes that we measure. So those are our basic outcomes. And then we wanted to say, well, how does this work? Because it was an extraordinary set of results that we came up with. This is initially about a decade ago. And we wanted to understand why that was. And right from the beginning, we wanted to understand the mechanism of treatment effect in PACT. And this is very important for reasons I'll go on to explain. In summary, what we find is that the key thing that makes a difference when we're looking at the follow-up effects on ADOS, but also other behaviors, these school-based adaptation, for instance, is the same thing, is that the key thing that mediates these effects, in other words, is responsible for them, is this change in child communication initiations. That change that we are able to introduce into child's spontaneous social engagement is the key change developmentally that is responsible for all these downstream effects. That is an extraordinary finding. And it points up how incredibly important this social change is in the kids. We also showed that this social change in itself is caused by the change in parental synchrony. So the changes the parents are able to make is the thing that is responsible for this change. In other words, the logic model of the way we thought the therapy should be working is indeed the way that we see it is working in practice when we do this science. And, this is a powerful result, mechanism study of this kind, pretty much unique in autism science, intervention science, particularly when we're looking at the follow-up results here to get this mechanistic finding. And it points up how important this is. And one of the implications of that is for our understanding of autism development generally. And the inference here for child development, I would say, is that it shows us that autism is not, as was often thought in the past, an intrinsic primary social impairment. Sure, there are vulnerabilities, but actually what we show here is that autistic kids can be just as socially engaging. They can improve their social engagement if the environmental conditions are right. This is not an intrinsic fixed impairment that defines the problem. That is an incredibly important reframing of what autism actually is in development. So we can change child social engagement. Autistic people can socially engage. They want to, they have motivation if the environmental conditions are right. And what we're doing in the therapy is to make those environmental conditions in the family right for the child. And when we do that, they automatically, spontaneously, we don't have to do behavioral manipulation to get the change. They spontaneously want to be social, just like any child. That understanding of mechanism then allows us to do all sorts of flexible but powerful adaptations of the method. And I'm just going to tell you about some of them just for your interest so you understand the sort of way we're thinking about this. Because once you understand the key ingredients of the therapy, then you can say, well, how do we try and do this in other contexts usefully? And, you know, most of you are in South America, in Brazil, and, you know, this is exactly what we're interested in helping you to do, is to adapt this kind of method into local contexts. So one of the things we started to do was see if we could work in schools to make this happen. And this is the PACG trial that we did subsequently and published in 2021. And essentially what we did here is a multi-component adaptation. It's not PACT. It is a modification of PACT in which we went into schools and worked with the teaching assistants in schools with on average 6 sessions in school, alongside in parallel to working with parents at home with 10 sessions. And it's worth noting that these sessions that we used here are far less than we used in the original PACT trial. And we also had this dialogue between parent and school. So basically what we showed in this trial is that we got, and this is what's called a forest plot, which gives you basically a summary of the findings. We got exactly that. Actually wasn't quite as powerful as the original PACT trial, but we got good effects on parent synchrony, child initiations, and also we were able to do the same thing with the teaching assistant. So we were able to make them more synchronous and working with the kid. And we were also able to show that actually the kid in school responded in the same way to the learning teaching assistant as they did to the parent at home. They also improved their initiation. So an LSA is a learning support assistant, which is the person who works with the kid in school. So what we were aiming to do was to get the same intervention effect with all these people in school, in the parents and the in parallel in the school. We also showed improved parental well-being and improved child behavior, both at home and at school, challenging behavior, which was an important result for the parents. What we didn't show in the way that we'd done in PACT was an improvement on the ADOS and the BOSC. So this was an interesting thing. So we got a change in the dyad, but not in the generalization. And we were also able to do a mechanism test. And essentially what this mechanism test showed is absolutely fascinating. It's a bit nerdy, this, but hopefully you can see that for nerds like me anyway, this is fascinating. So the red lines show an effect. And basically what we showed is that, as I've already said, that the treatment had a good effect on parental synchrony, just like we showed in PACT. And it also had a good effect on the teaching assistant synchrony. And we also showed that improvement in the synchrony improved the child initiations. So you can see that in this diagram, the red line from synchrony to child initiations, both at home and at school. So we were able to show the same effect as we had in PACT. And we were also able to show that the child initiations, which were the key mediating thing in the PACT trial, also were linked to improvements in the BOSC outcome in the initiation with the parent and with the teaching assistant. In other words, this worked in exactly the same way the PACT worked. What was different is that this change that the initiation had led to was just not quite enough to make a statistical group difference. So it was a lesser effect. It was like it was a weaker effect, and that wasn't enough to drive the between group change to make the outcome significant, as we had shown in PACT. So it was the same effect, it was just a bit weaker, right? And this shows that the pathway is the same, but the pathway, the strength of the pathway that you can push through varies according to the context that you're implementing it in. And this is very important learning for us about what is really necessary to make this process work well. And what we concluded that there were two things that were probably responsible for this, the pathway being weaker in the school. One was dosage. In other words, we weren't giving them as many sessions as we had in PACT. That's important. So there is a dosage effect, just like with a medicine. You know, if you don't give enough paracetamol, you don't get the treatment, you don't get pain relief, right? It's the same sort of idea here. And also the environment that we were conducting it in schools was really complicated and difficult. And we thought that that probably made it more difficult. So the mechanistic thing here is preserved, but it's just a bit weaker. So there's good lessons to be learned from that trial. Then we adapted this for South Asia. And as you may know, we've adapted using the mechanistic results. We've adapted the work to be able to be implemented in South Asia with non-specialists. And this is the so-called PASS intervention, where we kept the core components, including video feedback, and we trained these non-specialist community workers, really are non-specialists. They had no experience of any kind of professional childcare work, these people. So we were able to train them up and get them to work with the parents because there aren't any other people available in South Asia. And then we built and maintained their competencies. And we've shown in a couple of trials that, and these are all published, that actually we got the same effect, that we were able to show this dyadic, what we call the dyadic change, the synchrony in the child initiations, even when the same mechanism is delivered by non-specialists. So it's really robust, this, to your treatment delivery if you train and support people properly. And in a big trial we've just finished in Delhi, we were able to test generalizable outcomes in a big trial of 260 children. Same core components as PACT, but delivered by these rural medical aides, the non-specialists. And what we showed here, this is a bit complicated, but essentially the result is very similar to PACT-G, the education result, in that we get very good change in the synchrony response and in the initiations in this Delhi. And this was a trial done during the COVID pandemic. So it had huge headwinds to it. But despite that, we got these changes. But we weren't able to show a change in the BOSC. And this is just like in the PACT-G. And also, just like PACT-G, we were able to show, however, that the pathway of mediation was preserved. In other words, that if the study was able to show increased child initiations with the parent, this core thing that I said early on was the key thing that we need to drive change. And we were able to show an effect on BOSC. It just wasn't quite big enough to drive the significant group between group effect that we saw in the PACT trial and the other trials we've done in iBasis. So this is a very similar result. It shows that, this is not magic. You have to have the right environment, the right training, and the right dosage to really push through this treatment effect to get long-term results. And that's wonderful learning for us as practitioners. So final thing I'll just talk about is implementing in the NHS in real practice. So all of this is real life stuff in everyday conditions. And we've done that in Australia and in South Asia, and I'll come to that. But particularly, we've been very concerned to see if we could implement this in ordinary NHS practice. And the way we've done that, as Catherine alluded to, is this pathway approach, where we have a detection triage, this is called SAXR, which identifies autism likelihood. It's not diagnosis, it's a detection of autistic trajectory likelihood. And then we put in either iBasis or PACT therapy plus other initiatives as appropriate. And the idea of this is it's a stepped assessment care model to try and make the whole process more efficient in a way of managing neurodiversity in a community in an efficient and effective, cost-effective way. And we've done that in South Asia. We're doing it at the moment in this big project called Namaste, which is across India, northern South India, Nepal, and Sri Lanka. This is a big project funded by the UK government. And we're in the middle of that, implementing this pathway using the adapted version of PACT called PASS in South Asia. It's an exciting project, which is going on for a few years. And then in the NHS, we've got this, what we call an integrated early care pathway that I published a few years ago now. We've been putting in over the last few years within the UK NHS. And basically, I won't go into this in detail, but the SACS work turns out to be very effective as a detection instrument. One of the big worrying things is that it might over-identify cases and flood the system, as it were, and it doesn't do that. In fact, the number of cases that it identifies in a community aligns with our kind of 1.3% ordinary kind of prevalence rate. So it is not over-identifying likelihood here, which is brilliant. And it means we can actually manage that in a therapeutic term. So this is really a manageable approach in a community. And what we're able to do implementing this is we've halved the waiting list compared to a couple of areas that didn't have this new pathway. And halving the waiting list is very important in a UK context because this is a real hot potato, both for politicians, but particularly for families and children having waited a long time for diagnosis. So we cut down the wait list for diagnosis by a half, and we've got very good clinical outcomes. These are the things we use classically in our clinical setting of goal-based outcomes. And we've got great responses from families, and Catherine's already spoken to this, so I'm not going to go into this now, but the families really are very grateful for this early care in a family-centered way. And this is a lovely quote. I don't think Catherine showed you this one, but this is from an autistic mum who was in therapy with us with her own autistic child. And she said, Pat made me feel confident in my own parenting. Everything I'm doing now is how I wanted to be treated as a kid. It was so lovely. And PACT's helped me come to terms with how I communicate. If only my parents had had this when I was young. So this is, wonderful testimony to the impact in real life, which complements the kind of science that we've done. And we've done a lot of evaluation, which has generally been very positive on the impact on the NHS. The key thing is trying to persuade people to make the system change, to put this pathway in. So with that, I'm going to finish. Thank you very much for listening. Happy to answer or answer any questions or have any discussion. Thank you very much.
Thank you so much, Jonathan. That was fantastic. So so helpful to see all of the impacts of PACT on different aspects of children's and families' functioning. And I really love how you highlighted that PACT has these positive effects, not only on cost effectiveness, but also on lived experience. So the people's experiences of growing up autistic and being able to communicate and interact socially, and also the kind of factors that influence how PACT works in different settings. So thank you very much. So I'm not sure if we have any questions. Let me just check the chat. Yeah, so maybe I will just take this moment. So one of our attendees, Louise, asked how PACT, what is the main distinguishing feature of PACT compared to other approaches? So what would you, Jonathan, and you, Catherine, say that is kind of the main features of PACT that differentiate it from other interventions?
Well, I think what I'd say is that it's a very clear and focused model. And, I've tried to show how the idea of what the therapy's supposed to be doing and the process of it is kind of carefully articulated. That's not always true in other therapies. And what we've been able to show, obviously, in terms of our science, is the mechanism and how it actually works in practice, which it really is unique in the autism literature. So there's no other intervention that's got that kind of granular detail of how the intervention works. If you say, well, what in the implementation of the therapy really is the standout, which makes PACT more effective than most other therapies, and I'd say that's what the science suggests that it is. I actually think it is the focused work with parents using video feedback. That there isn't another therapy, apart from iBasis, which is basically a similar model applied to infants. There isn't another therapy at all which really applies such a focused use of video feedback to help parents understand their child. A lot of therapies do something that's a bit similar, or they have a lot of relationship-based therapies do something that's a bit similar. But what they don't, and they use sort of various therapeutic techniques, which often involve direct work with the child from the therapist and the parent watching and a bit of coaching work with the parent. That's often what happens. I think what distinguishes PACT is how we are just very focused on precision in the video feedback. What we're really trying to do, the high level of precision in the manual about what the therapist is trying to do with the parent, their exploration. These things are real signals of a therapeutic process just working better because it's so specific. And generally, you get a more non-specific approach, which may have similar broad goals, but it hasn't got the same focus. So I think that's the reason why PACT is more effective and shown to be more effective than a lot of other similar therapies. And of course, then if you compare this to behavioral type therapies, so I'm thinking about the Early Start Denver model, ABA, basically behavioral learning based approaches, PACT is very different to them in the sense that they have a completely different fundamental model of how they want to make change. And they use behavioral learning theory, which is, has a long history, particularly in America, based on animal behavior models. And they're focusing very much on working with the child, most commonly, to use behavioral learning techniques, that's contingency reinforcement, to shift the child's specific behaviors. That is although it's superficially it can look a bit similar, that is actually a very different kind of therapeutic approach to what we do in PACT, which is based on this setting up a relational environment in which the child then spontaneously changes. In behavior learning therapy approaches, there's direct work to, as it were, mold the child's behavior using differential contingency reinforcement of certain behaviors, using reinforcers of various kinds. And although the sort of, as behavioral therapies have evolved, they've often talked about themselves in developmental and naturalistic terms. So there's this notion of the NDBIs. But actually, fundamentally, the mechanism of change that they postulate uses this behavioral learning theory approach. And PACT uses something very different to that. So there are superficial similarities, but where you get under the bonnet, as it were, as we say about cars, it's a very different kind of engine. And this video feedback model is very specific to PACT, and it's the effective component.
Thank you. Thank you. And Catherine, I don't know if you have anything to add to that.
Yeah, I totally agree with Jonathan. And I suppose the only additional component is that the non-directive approach, where it's actually looking at a balanced, the dyad. So we're not just saying do to the child, we're actually saying create a dyad. It's equally looking at the adult contribution and in a way that's giving a child this chance for initiation, looking at all. So there are different ways in which you can observe child movements and signals on video. You might see it as being a behavior. A child, for example, that's just doing something with play, saying cut, 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 and playing with a pizza. Now, that could be interpreted as a behavior because it's repetitive. But the way we look at that video is that it has meaning to the child. And we look at the positive attributes of that and say, he loves pizza. You can see his emotion of enthusiasm. And he really loves cutting the pizza. Now, because he is saying cut, 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 in that he is also inviting the adult to say, look how I love cutting pizza and share it with me. Can we have more pizza? And so we interpret it, and it's reframing something from a behavior to being a communicative, meaningful signal. And when that child gets that communication signal validated, it's saying, I really, really do love pizza. And then we talked to the aunt saying, what do you see happening here? And she said, well, we did have pizza the other night and he loves it. So we anchor it into, it's the child's experience. And he was absolutely passionate about pizza. So the response to that is radically different. Instead of trying to extinguish something that's repetitive and change it to something the adult believes the child should be doing, target driven, we're trusting the child, going with the child, saying this is a communication. We're anchoring it in the whole context and the interpretation, and then we're validating it and enhancing it, harnessing it to make it more powerful for the child. So it's very radically different to other interventions. And also we're training professionals to they put a hat on as to knowing what communication is and what it looks like. But that is quite a new skill, to knowing what play looks like, or what, they may know what a behavior looks like, but they don't know what communication looks like. And when it's non-verbal, it's equally valid to a child being verbal. We give it power. and we validate it and strengthen it. So we're getting the child to have a sense of worth, self-worth, that my signals are understood and then they're interpreted into meaning. And then we increase the strength of that. Now, whether that becomes a more rounded communication signal where it's more frequent or it's stronger, or whether it includes language eventually, all of those are equally valid, and we support the child in making that their voice heard.
That's such a lovely comment, Catherine, because that's a concern we often get from parents is, what should I do if my child is engaging in a repetitive behavior or is using echolalia or repetitive speech? What should I do? And that reframing of that speech in terms of it is something meaningful. The child is trying to communicate and share with the adult. That's such a helpful way of understanding the child's communication. So Gabrielle has a question, so maybe we can discuss this now. So he asked if PACT can be or should be used together with other therapies. So it certainly can be. So Catherine, I think Jonathan has to leave now, and thank you so much, Jonathan.
It's a pleasure. Yeah, I'm sorry I have to go. I will, but I'll let Catherine, I'm sure she'll be able to answer that from a practical perspective, no problem. But anyway, lovely to be with you.
Lovely.
And
thank you so much.
yeah, all the best.
Bye. So Catherine, would you like to comment on the kind of recommendations for how PACT can or should be combined with other therapies?
Yeah, the recommendation and in our trials is that children should receive the services available and that are appropriate for the child's needs, and therefore PACT can work alongside other interventions. However, if when we're delivering PACT, we find that there's an intervention that is leading to conflicting advice, then the recommendations is there's liaison, and we discuss our observations and understanding of the child. So we would quite often, liaise with other professional services and schools, and we'd come to a mutual agreement, and respect the views of the child and the views of parents and what their preferences are, with the aim of consistency across the child's environments. But actually, usually those discussions help. I'll give an example. So a school was trying to target a particular learning skill for a child. The parent spoke to the PACT therapist saying, felt this was leading to some distress and anxiety in the child. So we liaised with the school, and it was just literally the school thought that the parent expected them to be working at a higher level. And they felt, that, and within the education system, they felt that expectation on them. But when we made it perfectly acceptable to be more aligned with the child's current style and motivations and where they were developmentally, the school felt much more comfortable and felt they were very happy with that. It took the pressure off them as well, and they felt, validated that it's supportive when we all work together and we all have, a consistent picture of what's appropriate.
Thank you. So I think just one more question before we move on to the final talk. So Fernanda or Sati asked, what should we do if a child uses alternative communication method devices, an AEC device? Can this be integrated in the interactions in PACT?
Absolutely. So there is some separate research in Canada that found that the child's preferred mode and method of communication is likely to be more successful. So we are looking at all the child's modes and methods of communication, and it's on video. So if a child is choosing to communicate using objects or pictures or gesture or sign language, we will see it on video. That is their choice. And then all we're doing is using a method of interpreting that chosen communication method and what the meaning is the child is conveying by looking at the whole context. I suppose what PACT is not doing is it's not doing to the child, i.e. saying to the child, you should be using an electronic device, you should be using this communication. It's looking at a more naturalistic approach, a more spontaneous approach to communication from the child. And we go with that. We go with that method.
Great, thank you so much. Okay, so now we'll have our last talk. So this is actually me and Priscilla, but it'll be mainly Priscilla. So for those who didn't hear my introduction earlier, I'm Lizzie Shepherd. I'm a professor at the University of São Paulo. And I'm from the UK originally, but I've been living in Brazil since 2018. And in 2019, I got in touch with Jonathan and Catherine because I wanted to introduce PACT to Brazil. I thought it was an excellent intervention option for autistic children in Brazil. I then met Priscilla, and Priscilla took on this project for her PhD. So throughout Priscilla's doctorate, she ran a qualitative implementation study of PACT in Brazil. And then she's now planning her postdoctoral research, which is a kind of larger scale implementation study. And so she will talk about the fantastic work that she's been doing here in Brazil to make PACT available to professionals and families. So thank you so much, Priscilla.
Thank you, Lizzie. Thank you, everyone. Thank you, Catherine, for your great speaking. So, as Lizzie said, I'm Priscilla Godoy. I'm a postdoc researcher with Lizzie in USP. And I'm going to present now to you the steps that we've been working with PACT since 2019, since we beginning. So yeah. So first steps we needed to do when we decided to work with PACTinBrazil. No, actually before that, Lizzie and I work together, and we are discussing the needs that we've been listening from families of autistic children there in USP, in HC, where we worked at that time. And we actually realized that some gaps in our system and the kind of interventions we had here in Brazil until there are contributing to make some families not to have access to intervention and lots of children just to get any kind of support when they are older in their development. And many families use it to report to us that they really needed something that could help them to interact and to communicate with their children. Many families use it to tell us that sometimes they felt that they couldn't understand their child needs. So yeah. So back there, we understood that there are different kinds of gaps in terms of kinds of intervention we had here in Brazil. So we knew PACT, and we we started to study more about PACT and the papers they had about effectiveness and efficacy around the world. And we understood so that maybe it could be something very, very valuable here to our context. So, yeah, the first steps we needed to do was to translate and back translate all the material they had, which which is a lot of very, very detailed material. So they have a manual, a very explicative and very detailed, and with all the steps of the intervention and how to use all the methods and strategies when you're delivering PACT to families. So we did this translation, and then the next step was to understand if families and professionals who work with autism here in Brazil, if they would see the value we saw impact here to our context as well. We wanted to understand what kind of context they used to work and they used to have in their lives in the case of families. And we need to understand if they thought PACT could be feasible, it could be beneficial for autism here in Brazil, and if it could be if it could help as we thought in make interventions more accessible to autistic children in Brazil. So that's what we did. So we interviewed a lot of a group of families and professionals here in Brazil, and yeah, they actually as exactly as we thought, they understood the positive benefits of PACT. They understood that they need more or better involvement in their children. They need to be they needed to be a very active participant in their child development. So they really understood that PACT could improve their understanding of the child communication and behavior. And professionals as well understood that exactly because PACT is evidence-based and with very robust efficacy studies and methods, it could be very interesting and important for our context, especially in the public system when where we don't actually have a lot of or very qualified evidence-based interventions. So we also delivered PACT to families. So we delivered it back to 13 families, and then we also asked them what was their experience with the intervention, if the intervention brought benefits, and what could be the barriers they had during the intervention. And here in this case, we also had a very good feedback from these families, these mothers and fathers, these parents who exactly told us how the intervention could improve their interaction with their child and how the intervention could help them to understand better how to communicate with their child and how it, in consequence, allow them to teach their child during their development needs like autonomy development situations. And then, so with all this information we got from these families and professionals, we had some adaptations from the original manual because some information they said was about the frequency of the PACT sessions. So some families and professionals here in Brazil said that maybe more frequent sessions in the beginning of the intervention could improve the engagement of these parents in the intervention. So the original manual of PACT orientates 12 fortnightly sessions, but in our Brazilian adaptation, we have 4 weekly sessions in the beginning and then 8 fortnightly sessions. We also added some real life strategy examples in the manual to make easier for some parents to have insights and reflections about what we were discussing in the sessions feedback. And also we added the importance for the therapies to help very, very much the parents how to deal with some challenge they could have in their environment. So if we are talking about different cultural situations and different socioeconomic situations, we can have like families who have like more than 5 or 6 people living in one room in some kind of conditions. So when we are talking about something that this parent need to implement in their home, how to some challenges could appear here as barriers. So we also added some helpful instruction about that. So as a result of that, we now have our Portuguese manual version that is already commercialized by Hograph UK. That Hograph is known here in Brazil, but they have Brazilian Hograph, but we also have the UK Hograph. And so the manual is commercialized by them. And we also have published this paper with all the information I briefly brought here for you about how was this implementation, this acceptability and feasibility study that we run here with these families and professionals. So if you want to see in more details how this work was done, please you can access this paper in Altus. We also started at PACTinBrazil, which is our Brazilian franchise of PACT with all the support from Catherine and the UK Impact people to help us to now teach some professionals or all the professionals who wanted here in Brazil to start delivering PACT with their families, their patients. We know that we have, as Paula said in the beginning, we have public system and also we have private system who can offer support to autism here in Brazil. So now even like professions who work with public or private system can have the training impact and start to have this intervention as their work with autistic children and their families. And now we are in the phase 2 of our big implementation process, which are this large-scale hybrid study in SUS. So our main goal with PACT here in Brazil at the beginning was maybe to implement, to offer to our public system one intervention that could exactly goes with the needs of the services and the families and the managers of the services and the health policies makers. So, but even though PACT is already being implemented in health system in UK and other countries in Europe, and even though we understand that PACT can be very important here to our scenario in public system, we cannot affirm this before we actually study this in detail. So before we can provide information to health policies makers, we need data. We need studies, scientific studies that confirm our hypothesis. So that's why now, and a lot of people who are here in this webinar are the managers and therapists who will participate in this study, and I'm very happy for this. So now we are selecting, we are recruiting 2 services per Brazilian region that support children with signs of autism, which has exhibiting wait lists and located in cities with diverse socioeconomic and cultural contexts. We are going to train psychologists, speech therapists, and occupational therapists from the services with the regular PACT training to deliver PACT to children of their service, so to implement PACT in their services exactly the way the service is now. So we don't need and we don't want them to change anything they do because this is a real life study. So exactly what we want to know is if they if PACT can be implemented and provide more access and benefits to their families, the families they support. So to do that, we're going to use some qualitative and quantitative data collection as predictors of caregiver engagement. We're going to measure mental health of the parent to understand if any kind of symptom or a mental health condition could impact this engagement from the family. And also we are going to interview caregivers and therapists to understand what they thought about the intervention delivery. And we're going to use all this data we're going to collect on implementation science to do reflexive thematic analysis, mixed effects model, and integration of qualitative and quantitative data through triangulation techniques. So this is the part 1 of this phase 2. And now Lizzie are going to talk a little bit of the part 2 of this phase 2 of the PACT implementation, which is the effectiveness work.
Thank you. Thank you so much. Yes, so within this incredible implementation study that Priscilla is leading, we're also going to evaluate the clinical effectiveness of PACT in the Brazilian Public Health Service. So in all of the services that implement PACT, 2 services at least in all of the 5 regions of Brazil, we will also randomize families to either receive PACT straight away or receive PACT after a 5-month waiting list, which is the duration of PACT in Brazil. And then they'll receive PACT within the public health service. And we'll measure some key outcomes. So social communication skills of the child, the interaction between the caregiver and the child, and family well-being. And we've already designed the kind of statistical analysis for how we'll investigate whether PACT shows significant effects in improving these aspects of child and family functioning compared to waitlist control. So I think that was all I needed to say about the effectiveness trial. So that's obviously a large project, which is just starting. And then maybe I can just mention that something that we've come up against a lot in Brazil is, so a lot of stakeholders ask us, so what is the efficacy of PACT compared to ABA? And at the moment, although there is evidence for how PACT compares to ABA in the form of meta-analyses. So a meta-analysis is an analysis done on different studies that have been published in the scientific literature. And the analysis compares the treatment effect sizes, the magnitude of improvements in different outcomes for different interventions. And that has been done, and PACT and other developmental interventions show stronger effect sizes than ABA for social communication outcomes in children. But that's not a direct comparison of PACT with ABA. And so initially we didn't really want to do that kind of comparison because we don't believe in comparing, in kind of contrasting, kind of saying this intervention is better than this one and so on, because every intervention has its place. But what we are going to do now is we're hoping to do a trial that will compare PACT with ABA, and we'll compare the cost effectiveness specifically, because we want to show that PACT would be a very important intervention for healthcare plans to support. So at the moment, they only support ABA in Brazil. So this would be a really important next step for our context. And I think that was all we wanted to say. So I don't know, Priscilla, if you had anything else to add, or Catherine, I don't know if you have any comments to make on. Oh, sorry, Priscilla, you do have.
No, yes, sorry, thank you, Lizzie. I just wanted to show everybody here which are the cities we have services participating in our large implementation and effectiveness study. So we have at least 2 services per regions in Brazil. Brazil is very large with very different conditions and cultural and socioeconomic situations. So we really tried to do what we tried to do was to target this diversity. So we have small cities, big cities, we have cities in different kind of socioeconomic situations. So this is very important because we do know that PACT is we have the efficacy of PACT very documented around the world, but we also need to understand now what kind of barriers we could have here in these diverse situations and cultural and socioeconomic situations. that we could propose adaptations for different kind of services or families if needed. So yeah, if you have any doubt about our studying that's starting now, if you want to share any kind of clinic experience that could help us to design our studies, because of course, people who are there in dealing with the families and the public services barriers and difficulties, please, we also we evaluate a lot the feedbacks we could give us about this. We have an email, a website, Instagram. If you can talk to us with from all this, I don't know, social media. Thank you.
Thank you so much. Could we just take a can I do a screenshot of us with the map? Priscilla, can you put the map on, and then maybe we can all smile and do a screenshot. So yeah, Catherine, I think we'd love to hear your feedback on.
Yes, I just think this is a really important, impressive trial, and the scale of it, it's very big, it's really prominent, it's rigorous. It'd be very interesting to hear about the diversity in Brazil and what is feasible, what's appropriate in the different cultural contexts where you're embedding PACT. What you think they'll feedback in terms of any adaptations that would mean it's more accessible, more appropriate to the context. This is exactly what we aspire to. It's fantastic. And our goal is that we want the maximum reach, making it accessible to all children equally, independently of where they live or their circumstances. So this is a very very important trial to all of us.
Thank you so much. So yeah, Priscilla, do you want to talk a little bit about how your experience has been with the services so far? Like even just recruiting them was an experience.
Yes, I think you can hear me now. Yes, so until now, we already have at least 2 services participating for all the 5 regions in Brazil. And we already collected the consent terms from the therapist who is going to be trained soon. And we also are now delivering to managers a form with some questions about the characterization of the services, which will be important data for us to understand the implementation and effectiveness later in the data analysis. And I have been doing some meetings with all these managers and professionals from the services, and it's going to be amazing because they're all very excited about the project. They're very excited about having PACT there. The feedback that I heard from all the services managers and therapists was that they really need some one intervention like PACT that could involve parents in all the process, and also which it's very they see PACT as a very good option to improve access of many families, and because they have a lot of wait lines, and PACT could be a very useful tool to us to give support for the families in this waiting lines. So yeah, I'm very happy about this, all those results we're getting in these meetings and seeing that PACT could be important to our country, that us, which is our main objective with all these studies. And also, I want to say that even though we are doing this study about implementation and effectiveness of PACT in public system, PACT has already the efficacy shown in all the studies we have. So for those who want to have PACT to their private or public work practice, they could have training already on PACT in Portuguese here with us, because PACT is already effective intervention, as evidence-based intervention, as you saw and heard here from Catherine and Jonathan's speech.
Thank you. Yeah, and we've also trained some professionals in Portugal as well. So we opened the PACT franchise in Brazil, but it's for anyone who wants to receive training in Portuguese. And we recently trained 6 professionals in Portugal, so that was really amazing as well. They will also be implementing PACT in their public health services. And here we've had some really nice feedback on professionals who've already done the training and are using PACT in their clinical practice. And we have some reports of that on our Instagram. So yeah, so I think there are no questions in the chat, but we are available for questions offline as well. And we will also share the recording of this webinar on the YouTube channel of PACTBrazil. We'll also send an email to everyone who registered so that they can watch it, so they can watch the recording. So I'd just like to thank again, Catherine. Thank you so much for being with us and for supporting our work with PACT. Paola, thank you so much for sharing your experience with DIR floor time and also your experience with all of the interventions for autism in Brazil. And yeah, thank you all for listening.
Thank you.
Thank you.
Just stop recording.